It has been said that opinions are like ass. Everybody's got one. But being right with your opinion may make a difference between you paying a fine or paying money back to Medicare versus just enjoying your life and going on coding and billing correctly. In this video, I'm going to share with you an interaction that I had with a very well-known auditor, coder. I love her. Her name is Terry Fletcher. She released a podcast today called E&M Leveling, or E&M Leveling with Medical Decision Making, Right or Wrong. And if you haven't been following her or listening to her podcast, I love her. She's very passionate about the topic of auditing and being correct and always backing up the information with actual Medicare and private payer guidelines. So if you're not following, if you're not listening, definitely take a listen. But she put out this podcast today outlining something that was released from E&M University. Now, I'm not a subscriber. I don't belong to E&M University, but this is something that was apparently mailed to her from E&M University called Rounds at E&M University regarding a primary care visit. Now, let me show you what the note says. This is the note. And if you are not able to read it, I will share with you that this is an established office visit with the chief complaint of hypertension and dyslipidemia. Now, chief complaint should be patient words, and I highly doubt any patient will come in saying that I have hypertension and dyslipidemia, but let's just ignore that for a second. Continuing on, interval history, no new somatic complaints, tolerating medications without any problems. And I'm just emphasizing that just so that you take note. Examination, blood pressure is normal, heart rate 72, respirations 20, lungs are clear to auscultation, heart regular rate and rhythm, no murmurs, rubs, or gallops, extremities, no peripheral edema. And the diagram that is below that shows a basic metabolic panel, hemoglobin hematocrit levels, normal LDL level of 72, and one would argue pre-diabetic hemoglobin A1C of 6.4. Assessment: stable hypertension and dyslipidemia. Plan: 1. Continue lisinopril. Number 2. Continue atorvastatin. Number 3. Return to clinic in 6 months with basic metabolic panel and lipid panel. Now, Terry sent this note to 5 different auditors. 3 apparently said that this is a level 3 visit, and a couple said that this is technically a level 4 established patient E&M visit. And Terry makes the point that this is really a level 3 established patient visit. So let's go on to the E&M University's explanation. This is only a couple of minutes, but I think it illustrates the thinking behind why this is a level 4. And I'll make a case that this is not just technically, but literally a level 4 visit and not a level 3. Okay, let's listen to the explanation from the folks at E&M University regarding this office visit.
This is a note for an established office visit. The note is 54 words long. To determine the level of care, we need to take apart what's going on here.
Okay, and I'm just going to jump in here. I don't really care how many words there are, as long as the documentation supports the level of visit. It could be 5 words. I don't care. As long as there's problem, data, risk, 2 out of the 3 showing me that this is a truly whatever level that you determine to be. I couldn't care less how many words there are. Obviously, for me as a practitioner, the shorter the better. Right? If you can convey the way that you are, how you are taking care of this patient based on the data that you documented, that based on the information you documented, I couldn't care less how many words there are. 54 words, 60 words, 70 words, 100 words, I don't really care. As long as you can show me through your documentation that you actually performed the care that is necessary to reach and E&M level. I couldn't care less how many wards there are. Okay, let's go on.
The patient has stable hypertension and dyslipidemia. Blood pressure is well controlled. You review some labs, all of which are normal. You decide to continue current medications unchanged and schedule a return visit in 6 months with a renal profile and a lipid panel. Total time spent is 25 minutes before, during, and after the visit on the date of the encounter. What's the correct level of care?
Now, you all know since 2021, E&M level is determined based on either on time or medical decision making. And I've already said this numerous times before. Taking care of patients and documenting and coming up with a level for your E&M visit based on medical decision making is much more efficient than based on time. Any situation where you're trading time for money, it is less efficient, okay, when it comes to productivity. I'll just leave it at that. What was just said, patient has stable hypertension and dyslipidemia. Blood pressure is well controlled as seen on the vital sign that was listed in the encounter note. And in assessment and plan, the clinician said that to continue lisinopril and atorvastatin, because based on the labs that were ordered from a previous visit, you saw that the LDL was well below 100 and the blood pressure based on vitals under good control. Very importantly, and that is not mentioned in this explanation that you'll hear in a minute, at the very beginning, the note says, and I'm going to try to share this with you. The note on top under interval history, and I quote, tolerating medications without any problems. Tolerating medications without any problems. Now that is part of prescription drug management. That will not be mentioned in the audio and video presentation that you hear. So blood pressure is under good control. LDL is normal. The clinician decides to continue medical therapy. Okay? And as part of that prescription drug management, the clinician assessed how well the patient is tolerating the medication and clearly documented that there are no side effects. The patient's tolerating the medication very well. That to me is unquestionably, undeniably prescription drug management. Now, I have done a video, and I'll link it in the video description, or if you're watching this on YouTube, I'll link it up here. I have gone into detail as to what constitutes prescription drug management in medical decision making. Simply listing the medication in your electronic health records without any mention of how the medication is working, or if you noted any side effects, that is not prescription drug management. What is outlined here indicating that the blood pressure is under good control as seen on the vitals, and looking at the LDL level as outlined in the clinic note, that tells me that the medications are working well for this patient. In addition, the clinician noted that there were no side effects. So clearly, to me, I don't know about anybody else, I don't know how much clearer it can be. Clearly, prescription drug management was performed, which is a moderate complexity risk, which is a level 4 risk. Okay? Let's go on with this explanation by E&M University.
This is a documentation grid for established office patients with the reimbursement and utilization data shown here. As you know, the previous requirements for specific levels of history and exam have been discarded and replaced with a medically appropriate history and/or exam, the extent of which is left up to the examiner, which means the level of care is now driven by the medical decision-making or the time required for the visit. Here we know the time spent was 25 minutes, so we just need to calculate the medical decision-making in order to determine the correct level of care.
Now, in Terry's podcast, she mentioned that if you notice here on the two right-hand columns, the amount for the payment for each one of these levels is listed here, according to the 2023 Medicare Physician Fee Schedule. In addition, what she did not mention was that the percent utilization per 2021 Medicare Part B physician procedure summary data for internists is also listed over here. Now, she was complaining that why did this person list the payment for each one of these levels in this table? I don't know. It doesn't matter to me. As long as we know what the appropriate level is, and as long as you know what constitutes a level 2, 3, and 4 and how to get there. Let's go on.
Looking at the medical decision making and starting with the problems being addressed, here we have 2 stable chronic illnesses, which means this encounter would qualify for moderate complexity medical decision making based on the problems being addressed. The next step is to check the data reviewed.
And the 2 chronic problems are hypertension and dyslipidemia. Okay, let's go on.
Looking at the data reviewed, we did review 4 lab panels, but we ordered those at the last visit, so we would not get credit for reviewing the results during this visit. However, we did order a BMP and a lipid panel for the next visit, which means we would qualify for low complexity medical decision making based on the data reviewed. The last step is to check the risk.
Now, keep in mind the chart, the note outlined a basic metabolic panel, that diagram that is shown there with the numbers. And for the auditors who are not familiar, that has been in use for decades to outline basic metabolic panel and CBC, but in this case, only hemoglobin and hematocrit are shown. LDL, okay, so you have BMP, you got H&H, and you got LDL, and you got hemoglobin A1C. So that's 4 data points. And as mentioned, this was ordered from a previous visit that you're now reviewing today. So remember, when you order a lab, it is considered you ordered and reviewed the lab. So at this visit, just because you're reviewing the lab, you don't get to count that because you had ordered it, and that is considered ordering and review. So when you look at it and celebrate, think about it, you can't count that as part of your data. That's why in the audio description, he is only counting the 2 data points that you're ordering at this visit and not review the 4 data points, 4 lab values that you ordered from a previous visit. Okay, let's go on.
Looking at the risk, we clearly engaged in prescription drug management by explicitly stating we were going to continue the current medications unchanged, which means that this encounter would qualify as being of moderate risk. So 2 out of 3 dimensions are needed, and in this case we qualified for moderate complexity medical decision making based on the problems being addressed and the risk.
And once again, 2 medications. Well, you actually just need 1 medication. You just 1 medication, and you would qualify for a moderate risk. But let's look into this again. You have hypertension that is well controlled based on vitals, and LDL level that is normal. Okay, that tells me, as anyone who has any sort of clinical background, when you look at that and you see the medications that are being continued, it clearly shows that the blood pressure is under good control, and the LDL level, this lipidemia is under good control by atorvastatin. Clearly, okay? In addition, the cherry on top, this clinician, according to this note, said that the patient is tolerating the medication without any problems. I don't know how much clearer that can be that there's prescription drug management going on, okay? Other than the fact that, and I'll show you what Terry wants as an auditor. And that is the disconnect between an auditor who is not actively using the note, who sees patients and notating that way, and a clinician who, any clinician looking at that note would clearly understand that this is what is going on. But in today's world, where the clinical note is not just a clinical note, and you're using that clinical note to justify why you are billing a certain level, which is a sad state of affairs. But if you continue and you are a part of this third-party payment scheme, you unfortunately have to play into the game, treating the clinic note as not just a note to take care of patients, but also to justify your coding level. And to the untrained auditor, I'm not saying that Terry's untrained, but to someone who's not familiar with looking at a note as documented in a typical office visit, that, and it's we're not talking about electronic health records. Back in the day, those symbols, that notation is commonly used to notate basic metabolic panel and the values for a CBC. But anyway, that aside, there's a disconnect between what is actually written and what the auditor wants, and I think that's what the problem is. That's why there's the discrepancy between the 3 auditors who said that this should be a level 3 and the 2 auditors who say that this is a level 4, plus me. I look at this and I say this is clearly a level 4 visit. But anyway, let's go on.
Now that we know the time spent and the medical decision making, we can select the correct level of care. Here we spent a total of 25 minutes on this encounter, which means we would qualify for the 99213 level of care if we coded based on time. On the other hand, our moderate complexity medical decision making would point us toward the 99214 level of care, which is the correct code for this visit.
Okay, there you go, right? Based on time, it's only a level 3, but medical decision making is clearly a level 4. Let's go on. All right. I am going to share with, and for those of you, in case you're wondering who I am, I'm John Lin. I'm a urologist in Gilbert, Arizona, and I'm live streaming this to the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. And it's all done for free, not behind any paywall. I'm not charging you anything. I'm not trying to sell you a course or whatever. Anyway, in case you don't know who I am. So I exchanged emails with Terry, and I love it. She's just so passionate. And this is her response regarding the evaluation management visit that we just coded. And she said, there just wasn't, quote, risk, end quote, for me that had a moderate level, and MACs, or Medicare Administrative Contractors, are asking for expansion on the prescription drug management. But with no new complaints and no, quote, status, end quote, besides stable for the chronic conditions, and a diagram or schematic that was not self-explanatory. Prescription drug management is based on documented evidence that the physician has evaluated medications as part of a service that is provided. So there's a lot to unpack there. I think I've already belabored the point that there was truly prescription drug management going on as per that documentation, which in every encounter, whatever that note is, should stand alone to justify a level. I think clearly there's prescription drug management. Now, but with no new complaints and no status besides stable or chronic conditions, and the diagram or schematic was not self-explanatory. Unfortunately, Terry, diagrams and schematic do not, for an auditor, yes, if we are writing every single note for the auditor or for billing, then yes, you would ideally want to list, this is the sodium, this is potassium, this is chloride, this is CO2, this is BUN, this is creatinine, this is glucose, so that the auditor can understand. But to any clinician looking at the note, that is extremely clear to us. There are no new complaints. So what that there are no new complaints? The conditions are stable. You have 2 stable chronic conditions. I couldn't care less that there are no new complaints. And the status being stable is adequate. You have 2 stable chronic problems. Hypertension, well controlled with medication, and dyslipidemia, well controlled with atorvastatin. All right. And she wrote, prescription drug management is based on documented evidence that the physician has evaluated medications as part of a service that is provided. And once again, I'm going to refer you to the video. Again, I'm going to list it in the card up here that I used discussing specifically what is prescription drug management in a urology setting. But I think clearly there is prescription drug management in the note that was shown in this particular example. Terry further wrote that physicians, in this email exchange with her, physicians should make a direct connection between the medication that is prescribed to the patient and the work that was performed on the day of the clinic visit, such as, quote, stable hypertension, continue valsartan 10 milligrams, will refill for 4 months until next follow-up visit, end quote. ideally, right? In the ideal world, you want to satisfy the coders and billers and auditors. That's ideally what you want to do, okay? But in real life, when you are only given a short amount of time to see a patient, you need to be succinct and cogent in your note taking and your note writing. And the standard by which you should document your note is that if you were to pass away, anyone else picking up that note the next day should know what you were thinking and what you plan to do with that patient. And that is actually the Arizona Medical Board's requirement for you to practice, and the level of specificity and detail that you need to document in your note. For the note under consideration, that is clearly understandable to me based on the labs, based on what was written. Could more have been written to help the auditors and the coders? Yes. As Terry outlined, right? Valsartan, to refill the valsartan 4 months until the next follow-up, and hypertension stable. Ideally, you want to dumb it down to that level. I hate to say it, but that's what it is. You want to dumb it down to that level so any person looking at it can look at it and understand that this is why the level is justified. But real life is that you are time constrained and you need to be cogent with your notes. So the note as written, the note that's under consideration, in my opinion, is clearly a 99214, without a doubt, based on medical decision making. I would love to hear your thoughts regarding this conundrum that Terry and I have. I don't have a conundrum. I clearly think that this is a level 4 evaluation and management visit, and clearly prescription drug management was performed for this visit. I would love to hear what your thoughts are. As always, thank you so much for the privilege of your time. Please take care of yourself and take care of each other. Bye-bye.